So I'm Dr. Wallmann from the Lund University in Sweden, and I'm presenting this poster on the prevalence of IBS, the Irritable Bowel Syndrome, in patients with axial spondyloarthritis. So as the community is by now very well aware of, there is an increased frequency of inflammatory bowel disease in patients with axial spondyloarthritis. And colonoscopy studies have also shown that up to 50% of patients have subclinical IBD lesions. But in this study, we were more interested in the functional bowel problems, that is IBS. So what is then IBS? Well, it's a recurrent pain or discomfort in the stomach, which is coupled to at least two of the following: relief upon defecation, or a increased frequency, or a change in frequency, or a change in the consistence of the stool. And it's considered to be non-inflammatory. So in the general population, previous big studies have shown that around 11% of the general population suffer from IBS. And we now wanted to look into this problem in the AXSPA group. So in this cross-sectional cohort study of patients with axial SPA that we call the Spartacus study, which we're currently including patients to in southern Sweden. In this study, we looked at 37 patients with non-radiographic axial SPA and 68 with ankylosing spondylitis. And they all fulfilled the Rome-3 questionnaire, which is what you use to diagnose IBS. And we found that in the combined AS and non-radiographic group, it was 30% of patients that had IBS. And so almost a third of the patients had IBS symptoms. But then, of course, you wonder, so could it be that in some of these patients at least, a subclinical IBD type could explain these symptoms? So then we also made a stricter definition, where we looked at the patients that fulfilled the IBS criteria, but at the same time had a fully normal fecal calprotectin below 50, which I would say is a very conservative cutoff. If you ask gastroenterologists, they would normally say that below 100 speaks against having an inflammatory bowel disease. So with this strict definition, if you combine the two groups, there was still 19% who had IBS at the same time a normal calprotectin. And the real figure probably lies somewhere in between 30 and 19% then. And that should be then compared to the general population, where there seems to be around 11%. So based on that, we think that maybe IBS is more common in this patient group than in the general population. And finally, if we also look to patient-reported outcomes that we normally study in axial SPA, the patients with IBS had worse outcomes, significantly higher VAS global, significantly higher BUST-I scores, and also quality of life according to EQ5D was significantly lower. And it may be, I mean, in the general population, IBS is sometimes related to fibromyalgia or generalized pain problems. And it may be that, this is also the case in this group, which we are currently looking into more, but we don't have these data as yet. So that's basically what we have found. Thank you.
Dr. Wallmann, thank you very much for this excellent overview of your poster. Could you just tell us a little bit about your personal Congress highlights?
I would say that the main highlight, or the main thing that I've been thinking is of interest from a clinical perspective. Yesterday I saw two studies, one from Denmark and one from Holland, that had looked into MRI findings in the sacroiliac joints in healthy controls. So it were healthy people and they didn't have any back pain at all. And in these two studies, it was between 25 and 30% of them that actually had MRI lesions in the sacroiliac joints that were fully compatible with the ACEs definition. So this is clinically very important knowledge, that we know that we should not trust the MRI to 100%. We need to put it in a context of other symptoms and HLA-B27 and other things. So we shouldn't just look at the MRI. So that's probably my highlight from the Congress in terms of axial SPA.
Is this something where your future research might look into too?
MRI, well, we are not, in this Spartacus cohort, we do have MRI of a certain subgroup, but not of all the patients. So I don't think we can use this study to look into that kind of things. But we will look into, for example, the link between inflammatory bowel symptoms and, of course, also IBS symptoms, and how that relates to the development, or not the development, but the prevalence of radiographic changes, both in the sacroiliac joints and also with MSAS in the spine. So that's
Where do you think will research in terms of how to better treat those type of patients lead us in the coming years?
So in terms of well, when you have a patient that has IBD problems, inflammatory problems, then of course then you have to consider which medications that we normally use to treat AxSpA, which may be better to give them a monoclonal TNF or maybe sulfasalazine. But when it comes to IBS, which is then considered non-inflammatory, maybe would be better treated with symptomatic treatments that is used for IBS. For example, medications that keep the motility in the gut going, and sometimes they use low-dose tricyclics and stuff like that. So that may be of a greater interest in terms of IBS.
Okay, Dr. Wallmann, thank you very much for your time.
Thank you.